be brave if you're brave. I'll be brave, but only if you're brave. And it could be just you and me. We'll be family. Just wait and see. So I will fight if you'll fight. Yeah, I will fight, but only if you'll fight. Oh, we can make it through this like sailors in a tempest. Like sailors in a tempest together. And it could be just you and me. We'll be family. Just wait and see.
Good evening, everyone. Welcome to Lung Cancer Living Room Dallas. Thank you all for coming. Everyone in the room, those of you online who are joining us from wherever you are sitting tonight, hopefully having a glass of wine like everyone in the room here tonight is. We're so excited to be here in Dallas. This is our second time doing a regional living room out here in this part of the country, and we couldn't be happier to be here. So what I'm going to do next is I'm going to turn over introductions to this amazing panel for those of you who may not know who they are. Doctors Mason, Kirkpatrick, Gerber, and Nurse Melissa, who, from what I understand and what I hear around the room, is quite extraordinary. Some of the things we're going to talk about tonight are going to point towards, cancer is not exciting for any reason to a patient. There's nothing exciting about being diagnosed with any kind of cancer, right? But what is exciting for the folks that work in it, and some of the things you're going to learn tonight, from screening and early detection and surgery, you know, right on through even treating metastatic disease in a way that we never treated it before, right? And we're going to talk a little bit about, you know, in the last, you know, small handful of years, the amount of drugs that have been approved that, you know, is a huge number compared to the amount of drugs that have been approved over the last couple of decades, several decades, right? So things are exciting in lung cancer right now because of that very thing. So I'm excited to share all of that with you and those of you online. We're going to start a little bit with talking about screening, which I know is irrelevant to most, if not all, people in the room and watching because you've already been diagnosed, right? But what we view it as and why we would like to educate this population on it is because we think it's an opportunity for you to have a conversation with someone who might qualify. There's, you know, roughly between 9 and 10 million people in this country alone that currently qualify for screening, and roughly 2% of people actually go and get screened. So there's sort of this low-hanging fruit that you guys are the perfect folks to go out and be sharing this information. So I would like Dr. Mason to talk a little bit about screening protocols and what that looks like, and then we'll jump into some amazing changes in thoracic surgery.
Sure. Well, I mean, I think most of you know that lung cancer, if it can be cured, the chance to cure it is in its early stages. That doesn't mean there aren't exceptions, but for the most part, curability comes in its early stages. So obviously the question is, how can we find cancers in their earliest stage? And there have been a lot of different ways and a lot of different attempts to find patients and to screen patients. And screening in terms of, you know, the logistics of it can be quite challenging, but to screen patients and try to find it in an early fashion. And there have been many attempts, but really the one proven method, and while there are many other investigational techniques right now, the one proven method that clearly finds cancers early and saves lives is through CT scans. So they call it LDCT, low dose CT scan, and basically patients who carry risk factors for lung cancer, and obviously we know that the greatest risk factor for lung cancer is smoking. Those patients who carry risk factors should be screened with a low-dose CT scan to see if there's something on the CT scan that suggests that they might have lung cancer. So there are programs throughout the country, and I'm sure in everyone's city for the most part, that offer CT scans for people who are at high risk. And without going to the specifics of numbers and ages and pack years or whatever, it's basically patients who are a bit older, because it takes, patients who get older, have the opportunity to develop cancers, who are a bit older and who have smoked in the past or are active smokers, should be screened with low-dose CT scan. It's just something that your primary care physician should note as part of their evaluation. It's kind of like you get a PSA or a colonoscopy at a certain age, you should get a low-dose CT scan. So, that's what people should be having done. The one thing that I like about it is that it's something that clearly should be done and has the opportunity to find early cancers. The one thing I don't like about low-dose CT scan, or not necessarily, about the concept of screening in that population, is because many patients are not smokers. It sort of focuses more on smoking, and I don't like that sort of stigma that it becomes attached of a self-induced disease and smoking. That being said, if you are in that category, you should get screened, but that's not all there is to screening, and there are other, maybe you might be able to talk about other opportunities for screening that aren't necessarily as proven, but clearly getting screened is important, and it should be something that your primary care physician should be doing.
It's a challenge, and there's a lot going back to screening, whether it was mammography or colonoscopies and all of that, where there are lessons to be learned there. But lung cancer screening is interesting. I'm going to share a quick story, and then I'm going to ask for feedback on screening. I was recently at the doctor's for something trivial. It wasn't a big deal, but I was sitting. It was my GP, and I was sitting in the not the waiting room, but the whatever you call it, the room waiting for him to come in. And there was this ginormous poster on the wall talking about sort of screening protocols and vaccination protocols, literally from birth through life. And it categorized it by age, right? This is when you do this, this is when you do this, this is when you do this. And of course it got to I think it was like 49 to 65 or something range. And there was nothing in there about low-dose CT screening for lung cancer. And I thought, well, this must be an old poster, right? And I was like, no, it was like 2018. And I'm feverishly trying to find who do I email at this hospital to let them know that this is not acceptable, because why are we missing that mark, right? And there's a ton of reasons and I don't want to make this all about screening, but again, it points back to an opportunity for you guys to share this information that screening is available for, to Dr. Mason's point, a small percentage of the parameters aren't as big as we'd like it to be, right? They don't include never smokers and that sort of thing, but it's a start. So any comments?
Let me just say, we had our meeting. We have a monthly meeting where we look at all our screening CTs at our program. And it's not just getting a CT. I mean, you get a CT scan, and then if there's suspicious findings, we review it, like in a tumor board setting where you have a surgeon, typically radiation doctor, sometimes we have a pathologist in there. It's a multidisciplinary review. And so the CT, if there's a concerning finding, it's getting reviewed. If it's done properly, that's how most programs are set up. And so it's not just getting a scan, it's getting it reviewed, and then so when we get the word out to the internist that, hey, not only is your patient getting a scan, but if we find something suspicious, we're evaluating it and we're coming up with a plan. So I just think it's more, we just gotta get the word out better. You're right, it's not, we haven't done enough to promote that in the community. You don't see advertisements about it for some reason. It just we need to be better about advertising this great service, because it's really important. It's really important thing for patients.
Thanks.
I'll add a couple more thoughts. I think one of the reasons why we haven't seen as much CT screening uptake as could occur and as I'd like to see is that both the general public and physicians have been concerned about the complexity of the process, and some of that may be appropriate concern, and I think a lot of it isn't. So when a patient goes for a low-dose CT scan, the first thing you need to know is that it is indeed low dose, the amount of radiation is less than 1/5 a standard CT scan, so it's safer. It doesn't take a long time. The patient goes into the CT scan machine. He or she is asked to take a breath and hold it, and then exhale, and they're done. So it's done in a matter of seconds. And there's no IV contrast, so you don't need an IV placed, and you don't have to worry about allergic reactions or kidney toxicity. I think physicians were very concerned about low-dose CT because when you do very sensitive imaging studies, you see a lot of stuff. You see a lot of dots in a lot of people. As a matter of fact, in the trial that was done over time, 40% of the people in the study had dots that needed to be followed up. Didn't mean they needed to be removed or biopsy needed to be done. Of those, a very small percentage were cancer. Well, by 2019, what we have now is a system similar to the formal system that's existed for mammography for decades, where we have formal criteria to follow up all of those scans and rate them and decide which ones need to be evaluated in a special way. And when you use that system, less than 10% of the time do you need to do anything besides continue once-a-year screening. And the other thing to remember about screening is that it really is effective. The number of mammograms that you need to do to save a life from breast cancer is about 800. The number of sigmoidoscopies you need to do for colorectal cancer is about 700. The number of pap smears that you need to do to save a life from cervical cancer is over 1,300. And the number of CTs you need to do to save a life from lung cancer is 300. So by a factor of more than 2, it's the most effective cancer screening that exists.
That's a great point. So I'd like to kind of jump into early stage disease and how surgery really has changed. So also for those of you who don't know, Bonnie of the Bonnie J. Dario Lung Cancer Foundation is my mom. So she was diagnosed in 2003, which was when lung cancer entered my life, and I've been doing nothing but lung cancer since then. But she wasn't offered actually any options at the time, and without going into it, ultimately she wound up having surgery after being treated with chemotherapy and radiation up front, and she's still here today. So that's a big deal. But things have changed a lot since then. So I'd like to talk a little bit about video-assisted thoracic surgery and Da Vinci and all of that kind of stuff. So I'm going to turn it over to you. First, but also who qualifies and how does someone qualify for surgery and what does that look like?
Let me just ask, who's had surgery for lung cancer out there? So a lot of people. How many people had like a big incision versus like big incision? How about a telescope? Little incisions? Little incisions, okay. Wonderful. Stepping back and looking at surgery, and I think you're going to also talk about surgery at some point for more advanced cancers as well, but surgery for sort of more early stage. Everyone knows they're staging a cancer. Almost all cancers are stage 1 through 4. 1 is the earliest, 4 is the most advanced. Without going into the exact specifics, 1 means basically you got a spot in the lung. 2 means you got a spot in the lung and maybe a little bit of spread within the lung or into lymph nodes or drainage basins of the lung. Stage 3 means those cancer cells have left the lung and are starting to get more into the center of the chest. Like breast cancers tend to spread to the armpit, to the axilla, so they sample the lymph nodes. And in the chest cancers, lung cancers, they tend to spread to the center of the chest. So lung cancers that have spread to the center of the chest but have not exited the chest are stage 3 lung cancers. And then finally, stage 4 lung cancers are cancers that have traveled elsewhere, more distantly, to the brain, to the liver, to the bone. In general, lung cancer is reserved for patients with stage 1 to 3 lung cancer, so cancers that are within the chest. Surgeons can only treat what they can locally, remove the tumor. It's nothing, so fancy. Take the tumor out and everything in that region. So stage 1 cancer, stage 2 with the lymph nodes, and even stage 3 cancers, which you tend to treat with multiple different treatments, usually before the removal of the lung, or cancers that we operate on. So that hasn't changed a lot, I would say, in a long time. in terms of what operations we do for patients and who are candidates for surgery. In terms of how we do it, that has changed significantly. You know, in the old days, which wasn't that long ago in my training, and which wasn't that long ago, I finished training in 2003, you know, almost every operation was done with what's called a thoracotomy, or you make a good sized incision, you spread the ribs, you take out that piece of lung, you close the ribs, and the recovery is challenging and it hurts and it takes a while. You know, we still remove typically a lobe of the lung. You probably all know that there are lobes of the lung. The right lung has 3 divisions or 3 lobes. The left lung has 2 lobes. That's just the way it is. I don't know why. And we typically, you know, most cancers live in a lobe of the lung, sometimes right smack in the center and require removal of the whole lung, but usually in a lobe, and we typically remove the lobe of the lung. Remove the cancer, the drainage basins of the lung, and that tells us if there's movement, whether we need to give other treatments after surgery, that type of thing. Nowadays, most lobectomies or removal of the lobe of the lung can be done with little incisions, no rib spreading. Small incisions that, you know, typically people are able to go home with, you know, home from in a couple of days. There's VATS, video-assisted thoracic surgery, using a telescope and small incisions and instruments attached to the surgeon's hands. And then there's robotic surgery, same small incisions, instruments attached to the end of a robot. I do both, which is better. I don't know. I don't think it matters that much. I don't think most people really believe it matters that much. But the point is that it's with little incisions, without the rib spreading, and patients seem to do better without compromising the cancer component of the operation. Obviously, you want to remove the cancer, remove the drainage basins, and do the same operation that you would do with a big incision through a small incision. So most patients can have that done now, and I think that's made a difference in terms of patients that we can operate on, patients who are able to, you know, were a little bit more fragile in the past, I think get through it easier. I don't know that it's changed necessarily the survival of patients, but certainly I think it's made the recovery faster, and certainly an operation that we want to do and everyone should have the opportunity to have in the appropriate setting.
So I think that's a good sort of segue into, you know, that being sort of how personal that conversation is and how personal those goals of care are to the patient, into talking a little bit about literally personalizing the treatment plan. So I want to talk somewhat about upfront diagnostics and what that should look like and for whom it may or may not be appropriate.
So I'd be happy to take a stab at this. And then Melissa, you're welcome to add your part, because actually the reality is often very different than the goal, and that's an important distinction. The first thing to understand is that, say 12 years ago, we understood lung cancer just according to the pathologic subtype. There was non-small cell lung cancer and small cell lung cancer. And within non-small cell lung cancer, we had some various subtypes. For the most part, most of those distinctions never impacted the choices we made for treatment. That was just something the pathologist noted, and we kept that in mind. And now in 2019, we recognize that lung cancer is probably 24, 25 different diseases when it comes to the molecular makeup of a cancer. And increasingly in oncology, not just lung cancer, but other types of cancers, we may focus even less on where did the cancer come from in terms of which part of the body, and rather, what is the biology of the cancer? And there may be some lung cancers that are treated quite similarly to breast cancers because they share the same molecular origins and the same molecular targets. Molecular targets have been important in breast cancer for a long time. We've looked at estrogen receptor and a molecule called HER2 for several years and even decades, and used that information to guide the treatment of that disease. And in that disease, historically, it's been very easy to get that information up front. And that's because most breast cancer cases are treated early on, where it's removed with surgery and there's a lot of tissue. So that's the first distinction from lung cancer. Whereas we've already discussed, most lung cancer cases are diagnosed at relatively advanced stages, where needle biopsies are done and provide much less tissue. In lung cancer, unless it's part of a clinical trial, these molecular tests are only relevant for stage 4 disease and that decision making. And so it can be challenging for the person ordering or performing the biopsy or the pathologist to know, is this a case where we need to have that information? And you can imagine a case that I might see where a biopsy was done at one hospital, saw an oncologist at a second hospital, and came to me for a second opinion, and now it's 4 weeks after diagnosis and those tests haven't been ordered. That's a big question, right? So how do we make sure this molecular testing is done? Because while not all patients are going to have a molecular target identified, each time we find a new molecular target, the number of patients for whom this could be relevant grows. And we have to remember that the therapy that we can use based on these diagnostics can be incredibly effective. So in a best case scenario, when I have the highest likelihood of immune therapy working in lung cancer, the chance of it shrinking is about 50%. But if I find a personalized medicine approach where I find a molecular target and I give what we call targeted therapy based on these diagnostics, that response can be 90%. So we can't forget about how important this is. The field has recently changed in a major way because for the first time, and this is less than 5 years old, we've been able to do these tests with blood tests. And this is an incredible advance. And I first became aware of this technology when my sister-in-law was pregnant about 4 years ago. And she said, we got the blood test back and we're not at high risk for something like Down syndrome. And I said to her, I said, blood test? I didn't know you could do blood tests for that because I went through medical school, it wasn't a blood test, right? The obstetrician had to do an invasive procedure, an amniocentesis. Well, I learned that when a woman is pregnant, about 12% of the DNA in her blood is from the fetus. And so they could figure out through a blood test in the pregnant woman which parts of the DNA were from the fetus and test that. Well, when you have stage 4 lung cancer, even a highly advanced case, only about 1% of the DNA is from the cancer. So the fact that we can now do a blood test and identify subsets of those DNA molecules that are from the cancer that might show us important molecular information to treat the cancer is remarkable.
Another good segue into side effect management, supportive care. Some of you may have heard it referred to as palliative care, which is for most cancer patients that I talk to a terrifying word because most oncology patients are associating that with hospice care, which are completely different things.
Completely.
Can you talk a little bit about
Sure.
that?
So I am also certified as a hospice and palliative care nurse, and I've worked in both areas. And so, the word palliative care seems to scare everybody, and I try to explain that you think of your oncologist as the expert at treating your cancer, but there are going to be symptoms associated with that, and this is the expert at treating those symptoms. They have access to social workers because, once you get diagnosed with this, it's hard for your caregivers, yourself, and it's kind of an emotional roller coaster. And so they have social workers and psychologists to help with that, and pain management. They'll help you with, we've talked about goals of care. They're really good about taking time to sit down and really working with you on trying to figure out what's important. And I think just as a general person without cancer, I think we all need to sit down and do our goals of care and set up our medical power of attorney, because it's just something important to protect yourself and your family, and they can help with that. Hospice, on the other hand, is when you kind of exhausted treatment options, and you kind of not going to be on treatment. You can get care at home. A lot of our patients still come back and see us just in case something does come up and maybe they're feeling better, and so it's not like a permanent thing. So if you start feeling better, and you can always come off. It's not like once you sign up for hospice, we're completely out of the picture and that there's no turning back. So, but they provide, they have spiritual support, nursing support, aides, and you can have as little or as much contact with them as possible. It's very individualized as well. So palliative care, usually the sooner you get that on board, the easier it is to cope with things and get through treatment and other things like that.
Yeah, this is an area where studies have actually been done to show that patients actually do better.
Prolonged, yeah.
Yeah, when supportive care is entered into the whole treatment plan at an early stage. And I know, again, in talking with patients over the years, sometimes patients are fearful of going back to their care team about what side effects they may be having for fear of being taken off treatment, right? And what they don't understand is that they're actually just making things worse, right? By not talking to their care team up front about that. Has anybody in here ever had used any sort of supportive or palliative care nurses or anything? No. Is it probably because as soon as somebody suggested it, you said no?
And we talked about like a multidisciplinary approach. And we talked about radiology, pathology, radiation oncology, surgery, but I think palliative care is another part of that multidisciplinary approach, because we all work together for the well-being of the patient.
Oh, I'll be brave if you're brave. I'll be brave, but only if you're brave. And it could be just you and me. We'll be family. Just wait and see. So I will fight if you'll fight. Yeah, I will fight, but only if you'll fight. Oh, we can make it through this like sailors in a tempest. Like sailors in a tempest together. And it could be just you and me. We'll be family. Just wait and see.